I will do a small version of it, which I will the important things he said. I will mention them. Yeah, we'll look inshallah. It's read from Surah Al-Fatiha.
Succes. Goed luck, hè?
Geachte gasten, beste familie, vrienden en collega's van Bagas. Wij als zijn paranymfen heten u van harte welkom bij de verdediging van zijn proefschrift. Hij zal dit doen door eerst zijn werk toe te lichten in een lekenpraatje, waarna hij vragen zal beantwoorden van zijn opponenten. Wij willen u herinneren om uw mobiele telefoons uit te schakelen, niet te applaudisseren tijdens de ceremonie, foto's alleen zonder flits maken. En voor degenen die niet aanwezig zijn, kunnen zij via de livestream de ceremonie volgen.
Good morning. Honored guests, dear family, friends, and colleagues of Bagas Wicaksono, we as his paranym wish to welcome you to the defense of Raditya Bagas Wicaksono. During this ceremony, he will defend his PhD thesis. He will do so by first presenting his work in a Layman speech, and after that, answering the question of his opponent. We would like to remind you to turn off your mobile phones or make it in silent mode. Not applauding during the ceremony. Applause is only allowed after the Layman talk and at the very end when the chair closes the ceremony. Also, please follow the Bedel's instructions for standing and sitting, and everyone kindly stay in place during the committee deliberation. And at the end, we can follow Bagas to the receptions. Thank you so much for your attention and enjoy the ceremony.
Hello, good morning, ladies and gentlemen, my dear guests, my families and friends, also for those of you watching from home. My name is Bagas Wicaksono, and in this moment, for 10 minutes or so, I would like to present what we have during our research. So the research is entitled Home Palliative Care in Indonesia, an ethnographic study of family involvement and local values. My supervisors are Professor Janet Bowles, Professor Dick Willems, and Dr. Amalia Muhaimin. About 8 years ago, when I was caring for my mom, who was ill with breast cancer, it was such a difficult moments for us and for the family. But during those experiences, my mom said this to me: from this experience of caring for me, I am sure you will learn something. And I hold on to that. At first time, I didn't really know what kind of things that I can learn during these difficult moments, but it turns out that what I can learn is palliative care. So it is an active, holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially to those near the end of life. It aims to improve the quality of life, not only the patients, but also their families and also their caregivers. And here, the definition is based on the consensus of International Association of Hospice and Palliative Care, so it's a little bit more updated rather than the WHO. And here, it is very interesting to see that suffering is health-related when it is associated with illness or injury of any kind. And also, it is serious when it should need some professional support. And in Indonesia, ladies and gentlemen, we can see that here, a beautiful map from Asia Pacific. The opioid usage in Indonesia is extremely small. So this shows how palliative care in Indonesia is quite lacking. So it exists, but only in some geographical areas and not really integrated within the healthcare system. In primary level, it is poor to fair in terms of the availability of palliative medicines, and home care services is unfortunately out of pocket. So this creates families bearing significant burden of caregiving. Meanwhile, there are limited studies that explore the conceptualization of good home palliative care and also what kind of local values that influence its practice. Therefore, this research aims to contribute to the development of ethical, accessible, and culturally appropriate home palliative care in Indonesia. And also, we would like to contribute to the global discourse of decolonizing palliative care. So the questions that I would like to answer during this dissertation is how do Indonesian health professionals and family caregivers alongside patients practice palliative care at home? And we would also like to answer what local values are important and enacted within these practices. So to answer these questions, what we have done is to do a combination of two research. The first one is a scoping review to look into the practices in South and Southeast Asia of home palliative care specifically. And then we did an ethnographic study for 11 months in Banyumas. That's my hometown. So I did in-depth interviews, participants' observation, and focus group discussions with multiple perspectives, including patients, family caregivers, and also health professionals. And then we analyzed the data empirically with empirical ethics approach. So I would like to show some of the, I think, important and also interesting pictures from our ethnographic study. This is the picture that shows the challenges of how it is very difficult to access healthcare. You can see the roads are rocky, not very smooth. You can imagine maybe the ambulance will go like shaking all the time. So it's real, the challenges are real. But also, the love is real. I can see that the love is shining out from the participants. Here, one of the participants is being cared by his son, still on a school age. And this is a patient with breast cancer being cared for by her husband, very loving husband. Unfortunately, some of the patients have already passed away, including this woman. And to this day, I still very much love her because she's really kind, also as another participants. So this really shows that these are real people that we are actually doing interviews, and we would like to show the voices from them. Now, this is also very interesting. You can see that the families and the patients, they are very creative in terms of creating some kind of homemade devices. So you can see here, this patient cannot go to the bathroom by himself, so he created this installation using pipes, plastic pipes, PVC pipes, so that the family doesn't have to bring all the urine and also doesn't have to lift the patient. And here, one of the patient's family is creating a hole in the bed so that the patient can easily defecate on the bed, doesn't have to go to the bathroom. And here is a family with a higher income. They can buy a portable toilet. So they are very creative and very resilient in trying to solve their suffering and burden of caregiving. Now, I would like to also show you what we have found during the literature study in the scoping review and also the ethnography. So first, the professional service. It should be there, but unfortunately, in our findings, patients and families are helping themselves, doing almost everything, like caring for the wound and also feeding and caring for the medication, so everything. And psychological support supposed to be within the palliative care package, but here the patient, families, and also health professionals are all very much reluctant to do this, so they're kind of like avoiding talking about these difficult issues. Religious and spiritual activities are very much there, and they are very much actively doing it, also passively by listening to some recordings, even without religious figures' involvement. Access to skill and information, not really good, but they also need information regarding traditional, complementary, and alternative medicine, because these are something that is close to them and also beneficial for them as well. And to deal with systemic barriers in the scoping review, we found that it's usually from the professional team who provide the support, but in our study, we found that the community is actually providing this support because they have this gotong royong, or some kind of like cooperation within the community to help each other out. Some interesting quotes. So here we can see how community is very much supportive. They are very close and intimate. They're making fun of each other, drinking some coffee in front of the house while I'm there. And then here, the quote is showing how psychological support is needed, but they are reluctant to do so. So the mother of the patients say that, I am confused if I have to talk to a psychologist. What to discuss? People will call me weak, people will call me not grateful, and therefore they stop from talking about these issues. So to answer the first research question, ladies and gentlemen, I would like to say that people practice home palliative care with local wisdom. The family involvement is very central. The spirituality and religion is very significant for them to help with the acceptance and also to increase the perseverance of these people, but also inspired by some local wisdom such as traditional, complementary, and alternative medicines, and also gotong royong. However, challenges do persist, and we should not say that because the community already doing this, then let's not providing support. No, we would like to also have a government role in providing better palliative care. Now, the second research question, how are local values enacted within practice? I would like to show you two quotes. The first one is ikhtiar to reach a cure, which is translated to making an effort, the best effort possible to reach a cure. So the patient is trying to do whatever is necessary because the most important thing is to be cured. And here, this shows how the patient's families are actually expecting for the other family members to help more. But in reality, it is not always the case. And so the patient's family is saying to me during the interview, it will be nice if the sister that is living in the other islands is asking about how mother is doing, what kind of food does she eat, and also some money to help. But they will never ask for it because they have the value of implicitness. So to answer the second research question, I would like to say that the local values are enacted and interconnected. So we can see lots of values inspired by Javanese Islamic perspectives, such as ikhtiar, making an effort, ikhlas, or being sincere, and also pasrah, or surrender, but also the value of implicitness in communication, in expectation, because this value is trying to preserve some kind of harmony and sincerity, but also it creates unresolved tension. So it's very complicated to see all of this, and it's very nuanced. But all of these values help us to understand the caregiving phenomenon, but also these values might be interconnected, and the implicitness, for example, it hides other values and other challenges. These require health professionals to be more active in exploring these kind of perspectives. So, the recommendations, what we would like to recommend for Indonesian palliative care would be to cultivate the local wisdom, to integrate home palliative care further within the healthcare system, especially in the primary care or puskesmas. And we would also like to expand the knowledge of traditional, complementary, and alternative medicine so that patients and families do have some safe space to talk about this and to really consider whether it is beneficial or might be harmful. And then we would also invite health professionals in Indonesia to inquire mental well-being because it is important, they need it, but they are much reluctant to talk about it. So it should be the health professionals who initiate this conversation. And lastly, we would like to also invite people to foster cultural humility by being aware of the local values and practices, but also staying curious and always try to explore individual perspectives. We would like to conclude this presentation by this slide. So local values indeed shape patients' families, health professionals' behavior, and also all of their practices in home palliative care. It drives them to do their best through creative strategies despite all of the difficult circumstances. Thank you very much for listening to the Layman's talk. Terima kasih, and I would like to dedicate this thesis to the loving memory and everlasting inspiration of my mama, Ibu Esti Pratiwi, to all of the participants who let me share their stories, and to all of us who had been caregiving for our loved ones. Terima kasih. Now we would like to wait for the committee members to enter the room.
So you don't forget it.
All rise, please. Thank you.
Dear guests, Welcome to this special meeting of the Doctorate Board of the University of Amsterdam on the occasion of the PhD defense of Raditya Bagas Wicaksono. Dear candidate, would you please read aloud the first part of the formula before you?
By authority of the Rector Magnificus and the Doctorate Board of this university, I shall during this hour, in order to obtain the doctorate, publicly defend my thesis entitled Home Palliative Care in Indonesia, an ethnographic study of family involvement and local values. I entreat all those who wish to voice criticism of the contents of the thesis to do so in a truthful and lucid manner, so as to provide an opportunity for an ordered exchange of views.
I would now like to give the floor to the first opponent. The first opponent is Professor Wicaksono, Professor End-of-Life Research at the Free University in Amsterdam. The floor is yours.
Thank you. By virtue of my right and with the permission of the Rector Magnificus, I would like to discuss with you the contents of your thesis. But first I would like to congratulate you with your thesis. I enjoyed reading it very much. It's nice to read about something else in the Netherlands. And it's nice to read, I learned a lot from the ethnographic study. It's always nice to read ethnographic studies also. So I really enjoyed it, and I congratulate you with the beautiful work that you did and the nice book that it presented. But I'm here to ask you questions. My first question is really about the implications of your study. You gave implications about palliative care in Indonesia, of course, because it was about Indonesia. But you've been also walking around here and seeing palliative care in the Netherlands. And I'm really curious whether, with your study and with your experience here, you have implications for palliative care in the Netherlands. What could we do better? What insights did you get from there?
Highly esteemed opponent, thank you very much for your kind words and question. So, implications from my study for the Netherlands would be this give broader perspectives of how people may behave to palliative care. For example, we've heard a lot from Muslim patients, for example, in the Netherlands, they're also trying their best to have the cure, although it is in a palliative phase. And the findings of ETR, for example, this might reflect why they behave in a certain way, but still we have to also be very careful because it is not always the case. It's also probable that their kind of attitude may also be influenced by other factors as well. For example, they have underlying values or goals that has not been reached by them. So this kind of provides some additional extra considerations for that. And also, I think from the practice in Indonesia that I have shown you earlier about the community and gotong royong, I think this is also very beneficial for the Netherlands because I have heard stories about how the Netherlands might have facing some kind of health personnel shortage in the future and might be relying on families in the future as well. And so how to also initiate the family to be more caring and also the community to be more involved. There might be some lessons to be learned from Indonesia, such as to try to look and to reflect what are actually the philosophies that is shared by the community in the Netherlands, for example, that might be similar to gotong royong, but might also be different. I think that would be my answer.
Yeah. And I was also thinking of this community because indeed that is something I think there's already staff shortage, but maybe there's also positive reasons to think about more community involvement. But how should we get started with it? Because we are not so good at it, I think.
Very interesting.
Not saying something strange, I think.
Yes. I think we have to start it very gently. So it's not like top-down approach where the government would say, dear Dutch community, let's do some community work. I don't think that will work. So perhaps trying to see from the grassroots level what kind of community work that is already there and then try to build up from it. yesterday we discussed a little bit about using some kind of WhatsApp group, so everyday technology that might be helpful to keep the community together and to share whether people in the community have some kind of troubles and problems, and then they might help each other to do a little bit. So really start small, I think, would be the way.
Yeah, okay. I think we are trying to do that, but maybe we will need more advice for that before it will really work in the Netherlands. Another question I have is about your review, because you decided to do it on look at South and Southeast Asia, since there were not enough studies from Indonesia. And in the discussion you say it's a strength, because the similarities between countries enhance the understanding of the topic. But you also say that the interpretation should take place with caution, because there are studies in specific regions in different countries. So we should be careful with generalizing it to different countries. Can you help me? How should we be cautiously interpreting it? I always think, yes, I have to be cautious, but how? What do I have to look for?
Yes. So I guess this is also the issue of perhaps transferability would be a better way to discuss this, because most of the studies in the scoping review are also qualitative studies. So therefore, when the readers are trying to interpret or trying to apply it into different settings, then they also have to see whether the settings are somewhat comparable. So for example, whether the resources are more or less the same, or the religion influence are more or less the same, and then the findings of the review might be relevant for that specific setting. So we ask too much to the readers to really do this hard work on comparing and interpreting and really considering all those different factors while trying to apply it or transfer it in their specific setting.
Yeah, and is it then not only caution because it's different countries, but also caution because it's different studies with different aims and different interpretations?
Yeah, I think that is also correct, Professor Brechia.
And you did find, I think, a lot of similarities between the studies and then maybe also between countries. Is that then not reassuring for your concern about your limitation?
Yeah, perhaps my concern of the limitations would be perhaps to apply to a country that is located maybe far from the South and Southeast Asia region. So for example, you may think about maybe in Europe, perhaps there are some parts of the Europe which might have similar context or similar resource limited setting, for example. So we still have to be cautious because there are also other influences or other factors that might influence the findings and whether they are relevant or not in that region.
Yeah, but then I saw in your review, you have this figure on page 49, I think, where there's 5 key elements of good home palliative care. And when I looked at it, I thought, oh, they might also maybe apply here. And I was doubting most about the one of religion activities. But then you said in the discussion, there were 2 studies that also confirmed that for Europe. So then I thought, are these then not universal elements even? And this is not only South or Southeast Asia. And what does that tell you then? And what does that tell you specifically about South Asia and about how to do ethnographic studies? Do you still need to do ethnographic studies then or not?
Right, yes, because the findings are also somewhat universal and also shared by different regions. So that's the challenge of whether or not this study can still need to be done, and that is also the struggle that I faced during the earlier phase of my PhD. But what is reassuring is that the specificities of each region or each town would also still provide some meaningful reflection, I think.
Yeah.
And although some kind of findings are somewhat universal, but still the specificities of every single part of the family or the region would still be very interesting, I think, to look upon and to reflect.
I agree. I certainly didn't want to write off ethnographic studies. And in your presentation, I saw the slide where you compared the two, so that was really nice. I think half answer to the question.
Thank you very much.
I want to give it.
Thank you.
Thank you very much, Professor Umuteka. Next opponent is Professor Christianti Effendi, Professor of Medical Surgical Nursing at the University of Gadjah Mada, Yogyakarta, Indonesia. The floor is yours.
Yeah.
You can bend it a little bit more over.
Yeah.
To your, the microphone.
Yeah.
Lower.
Okay. Lower.
Yeah.
Oh, it's nice. Yeah. Okay, Raditya. By virtue of my rights, but not without permission of the rector, I would like to have a short discussion with you, dear candidate, about the content of your thesis. First of all, I would like to congratulate you on this beautiful work. I believe this study provides new insight into the implementation of home palliative care in Indonesia and also other countries. I would like to take the opportunity to ask a few questions. It is well known that Indonesia has an extended family with a Muslim majority. Caring for ill family members is an obligatory and autonomy as a family issue. My questions are, first question, since you recognize key elements of good home palliative care, did this situation contribute to or hinder the implementation of home palliative care for your participant in your study? Maybe
Yes.
you can answer this question first.
Dear highly esteemed opponent, thank you very much for your really kind words and question. So the issue of autonomy in Indonesia is indeed very interesting and never-ending debate about it, but I would have to say that this is something that is very local, the relational autonomy that we have in Indonesia, and I would not dare to say that it is a hindering factor to implement home palliative care, but I think we can also see it as a strength, perhaps, Professor Christianti, because the family is actually already doing so much already. So what we need to do is actually try to help them and take them by the hand, try to provide care at home that might be more ethical or might be more appropriate in terms of medical care, and also that might be relevant to the palliative care principles. But yes, there might be challenges from the family involvement. For example, when deciding for which treatment or deciding whether the patient will still continue the curative treatment or palliative care. And I think this challenge can be faced by more dialogue with the family members. So creating some family meeting or involve them in a discussion with health professionals and not let them to think about everything by themselves. So to really take them by the hand.
Okay, so it's strengthen and also barrier about the autonomy as a family issue, right?
Yeah, yeah.
And do you think also involve the spirituality aspect in for the family to decide what they really want to do to the patient? What do you think?
Yeah, I guess in Indonesia, most of the interpretation of spirituality would be really taken to the religiosity, and I do believe that religious factors indeed influence how they behave and how they react to palliative care introduction, for example. So yeah, I do believe that it is indeed something that is significant for patients and also the families, and therefore I think as health professionals we should also be willing to also learn about this and not saying that this is out of my expertise, but trying to also look into it and discuss it a little bit more, and also be willing to refer it to another professional if available.
Okay, so finally, the second question. Your PhD journey began with the experience of caring for your own mother. Is it correct?
That is right.
Yeah. And your mother said that, oh, you can be learned from taking care of me. Yeah. And then, if your mother were here today, what would you say about the lesson you have learned and what you would change about the way you care for her if given a second chance? Of
Yes.
course, as a family member, not as a doctor. Please, take your time.
That's a very personal question. Thank you very much. Perhaps to reflect on the journey, I would like to listen to my mom a little bit more, rather than imposing medical care and imposing her to be hospitalized, because sometimes maybe she already know if the hospitalization will not be doing any better. So so perhaps to really listen to her a little bit more and to involve her in the decision-making process, because I think we're still a traditional family where the patient should not be thinking about these difficult issues, let the family do it. But I think the patient also has a right to say something.
So, the last one, what will you say to other family member in the same position, if as a family, as a son, of the illness mother?
I think it's very difficult to put this in one sentence, but perhaps first is to also acknowledge the patient's voices and their goals, their interests, their preferences, and then try to consolidate within the family and to have a more open discussion within the family. So hopefully that will create a better and more personalized care for the patient.
Yeah, okay, I agree, totally agree with you. I'm very satisfied. Thank you. Yeah, thank you.
Thank you very much. Also for coming to Amsterdam. Next opponent is Professor Budi Aceh, Professor of Health Financing at the University Jenderal Sudirman in Indonesia.
Yes, thank you very much. Dear candidate, by virtue of my right and with permission of the Rector Magnificus, I would like to discuss with you the content of your thesis. After watching your answer from two opponents, I think you're really tough for that, and congratulations for your thesis. My first questions, based on your research studies in Javanese culture related with palliative care, I think I see a social capital from the family, from the household who try to care the patient of palliative care. And if you try to leverage into healthcare system, particularly for the community healthcare system, do you think it will be something benefit? And then how you can deal and integrate it to the healthcare delivery, particularly for the primary care? Please.
Yes, highly esteemed opponent, thank you for your question. I agree with you that family caregivers and family involvement are social capital, and I think there will be some ethical issues also pertaining to that when we try to to involve them within the structure. Then perhaps it will lose some of the sincerity and the authenticity of the family caring when we are trying to really put it in this structure. But also, it will be something that is beneficial because then we can provide more support for the family. They might have more guidance on how to provide care at home. So I guess in questions like this, we have to always look it into different perspectives. Maybe 2, maybe 3, maybe even more perspectives. So your next question, how to leverage the family as a social capital for community care. Perhaps I would like to say maybe start with working together with the community volunteer or health cadre in the villages. And usually these health cadres are the ones that are already very close with the family, and they can seamlessly introduce the concept or perhaps a new way of caring from the puskesmas, for example, and then help them to navigate this. Yeah.
Okay, really nice answer. The second question, because of Indonesia has multi-cultures, and your research only based in Javanese culture, do you think that if you try to integrate your finding into healthcare system, in particular for the primary care, and you try to scale it up to the whole Indonesian or national wide, do you think can be adjusted to another culture in Indonesia? Because we are so many cultures for that. What do you think?
Yes, I agree that the multicultural elements of Indonesia is also a challenge because the differences are quite big. For example, in Minangkabau, in Padang, people have a different social dynamics or family dynamics compared to the Javanese and something like that. But what is similar from all of the culture, I think families are very much still respected as an important part of the patient and also the caring process, although it is practiced differently. So I guess to answer your question, perhaps yes, we can integrate the family within the healthcare system, but the adaptation or implementation should also be very much tailored to the specific local context in the region. And therefore, I think more research are needed. Research like this, for example, the ethnographic study or more qualitative study to really explore these local values and practices that might be beneficial for the care that we would like to introduce.
Okay, I think that's all my question, and I think it's really nice and good answer from your side. Thank you very much.
Thank you, Professor
very much.
Budi.
Next opponent is Dr. Natasha Lemos-Dekker, researcher, palliative care at the University of Amsterdam.
Dear candidate, by virtue of my right and with permission of the Rector Magnificus, I would like to discuss with you the contents of your thesis. Dear Bagas, first of all, I wanted to congratulate you with this beautiful and thought-provoking thesis. You have produced a very well-written and clearly structured dissertation about emerging palliative care practices in Indonesia. And it's been a pleasure to read it and also to be part of your trajectory in the palliative care around the world network. But I would like to take this opportunity to further explore some ideas in your work. And in your thesis, you make a strong contribution to debates on palliative care by generating knowledge from a global south perspective, Indonesia in particular. The field of palliative care is still very much dominated by literature from and on Western context, and you wish to challenge this. So now in your introduction, you write that you aim to contribute to decolonizing palliative care. And I would like to invite you to elaborate further on this. What does the term decolonizing mean to you? And how do you see it resonating or perhaps failing to resonate with the care practices that you observed in your fieldwork? And then from your understanding, what would a decolonized palliative care look like in practice? Given, like I said before, that the most concepts and models of palliative care have originated mostly in Western context. What beliefs or assumptions must healthcare providers unlearn in order to truly decolonize their practice? Thank you.
Dear esteemed opponent, thank you very much for the question. So the issue or the topic of decolonization of palliative care is also something that is very much relevant to these days. And based on the findings, I'm sorry if I cannot really answer all of your questions. I'm trying to answer it one by one. I think what is resonating from our study is that the traditional and complementary and alternative medicine are somewhat very much significant for the patients and families, and these are also something that most health professionals doesn't really have the confidence to talk about it because it is not part of their westernized medical training curriculum. And also, I think the Global North studies are somewhat lacking. There are some studies about this, but still lacking. So I think more light needs to be shed on this and how to integrate it within the practices. So for example, to classify what are the traditional practices that might be beneficial for the patients and what that might be dangerous, and then try to also introduce this even from the first time during the consultation with the patients. So I think that is one, and I think the next one would be, there are also some discussions about, for example, the frameworks or the indicators of how palliative care should be done. And I guess you are absolutely right. It is coming mainly from Western countries, such as perhaps, if I have to say, United Kingdom, or also maybe the Netherlands. So what we can also do is that try to also look into this framework and indicators by not only adapting the Western standard, but to really go together and co-create this within our own country. For example, I have learned about Professor Kristanti's work, try to create quality indicators based on Indonesian context. So I think this is also a way to decolonize palliative care by not only thinking that everything coming from the westernized, educated, industrialized countries are the best, but also to have this own, local significance that we can also use in our own practice.
Thank you. That answers the question.
Thank you.
Thank you very much. Next opponent is Professor Krause, Professor of Anthropology at the University of Amsterdam. The floor is yours.
Dear candidate, by virtue of my right and with permission of the Rector Magnificus, I would like to discuss with you the content of your thesis. Because I'm here to replace Professor Anita Hardon, let me make her present with quoting from her assessment. This is a very original thesis on a very important topic, palliative care in Indonesia. The empirical philosophical approach is well suited for the research objects, and the candidate does a great job relating palliative care practice to core Javanese values. She furthermore praises the novel ethnography and how you kind of combined it with existing knowledge of palliative care in Southeast Asia. And she mentions in particular chapter 6 about implicitness and how it shapes communication and how that can be used to improve the care by professionals. I myself was also really inspired by chapter 6 and by chapter 3, and my questions are about those chapters. I was also so intrigued about these chapters because as an ethnographer and anthropologist, I always like to learn from local terms and local values, and that's kind of what you do in these chapters. And please be invited in your answers also to explain that again to the audience. So in chapter 3, you talk about 3 values, making an effort, and apologies if I'm not pronouncing the words correctly, ikfia, being sincere, ikhlas, and being in state of surrender, pasra. And throughout the thesis, you show that curative overtreatment can become palliative undertreatment. And how I understand you is that you basically want to strengthen palliative practices from clinicians, but also the palliative practices within the family. So that's basically the challenge. And you show in these chapters if we look at these values, how we can do that. But then the task would be, in order to to move away from palliative undertreatment, to basically move ikhtiar towards palliative care, because this is usually associated with kind of intervention, with curative care. So how to shift ikhtiar from curative treatment to palliative treatment?
Thank you very much, dear highly esteemed opponent, Professor Christine Kraus, for your interesting question and also kind words. I would have to say this is something that is challenging in practice, because we can try to have a conversation with the patients and families about different interpretation of ikhtiar. So for example, they interpret ikhtiar as, I want more drugs, I want more chemotherapy, I want more and more. But then we can try to also introduce ikhtiar as a way to also relieve suffering by perhaps providing some kind of symptomatic drugs that is relevant for the patient's symptoms, and try to also provide more support, psychological support, social support. This is also all part of ikhtiar. We can try to introduce that, but it still very much depend on how they eventually decide what they want to do. And in Indonesia, we also have this harmony, try to not inflict the conflict between the patients, families, and also the health professionals, trying to avoid some legal drama. So I guess in practice, we can really try to have this conversation, try to interpret ikhtiar differently, but still the challenge might still be there. And then if the resistance are very strong, then we can try to revisit this in a future conversation, perhaps when new results are coming from the labs, and then perhaps then they can really start to interpret things differently, and also try to already look into what are the realities and what can still be done during this phase.
Dear Chair, can I follow up with a question?
Yes.
Yes.
Sure.
So, and in chapter 6, you bring up the value of implicitness, and this was a real eye-opener for me. I'm researching care systems for elderly in an unequal Europe, and there we often analyze how the implicit assumption who should do the care work is actually sidelining all the work to the family, and then very often in a very gendered nature. It's also sidelining the work to Eastern Europe, which has to send a lot of care workers and things like that. So there's a lot of shifting of tasks. So for me then, implicitness is something very negative. It's kind of like not making explicit where the power relations are, not making explicit what is gendered. So your chapter really challenged me there, because like what you show is that staying implicit means opening up space for somebody else to enact sincerity. So I thought that was really interesting. So you show this in particular within the family. So now I was wondering, how far could that value of implicitness in creating this space used to making palliative care also stronger on a systemic level?
Thank you. In systemic level, I think I really have to reflect and imagine a little bit on my brain right now, but I guess what I can answer is that sincerity is somewhat significant, and also the authenticity, and I guess this is something that should also be protected in terms of systemic level. So that's why in earlier discussions with Professor Budi, if I'm correct, I say something about not really putting family in the structure very much formally, because that will create it very much explicit, and therefore it might lose this sincerity and authenticity. So therefore, it is not like you are obliging the family to care, but to involve them within the care and to provide them with some guidance and with some space to grow in terms of how family can provide better care, but not like forcing them and putting them in the structure, giving them all of these responsibilities, blah, blah, blah. That would not be very wise, I think, in the culture of high contextualized culture.
Thank you.
Thank you.
Thank you very much, Professor Krause. Last opponent is Professor Angeman, Professor of Global Migration, Ethnicity and Health at the University of Amsterdam. I'm glad you made it, Professor Angeman. The floor is yours. Go ahead. Stops. The internet stops. Okay, then did you have some questions? Yes. We wait for Professor Angeman to be able to answer.
Oh, there it is.
Professor Angeman? Yeah. We wait. Just go ahead and we'll see.
So my second question, Bagas, for this research, you've done ethnographic fieldwork and you were an ethnographer, but you were also a physician by training. And in your thesis, you briefly reflect on your own positioning as a medical doctor and as someone from the region. I would like to ask you if you could share more about this. I would be interested to hear, for example, how this may have influenced your relations with the families and the care professionals you work with. And I assume that your positioning comes with specific knowledges and relationalities, which may be a strength, but may potentially also generate friction while doing fieldwork, or perhaps ethical concerns. And I wonder, how did you go about this?
Dear esteemed opponent, thank you for the question. So I guess this is very interesting to reflect on, and also with my supervisors we reflect on it a lot. For example, because I'm a physician, when I was coming to the patients' houses, they are very much happy about it, to have a doctor in the house. They're asking lots of things about medications, about the diets, and in that moment, I try to deliberate very fastly in my brain how to respond, and my decision was to provide the answer. So I was like going out of the researcher role for a bit, and then going back again as a researcher, so really having a flexibility in a sense during those fieldwork visits. And I think it is not creating friction, but more providing more rapport. So they are happy that I am willing to answer their questions too, and so they also willing to open up more about their struggles, about their family drama, about all things that are interesting, and also even after the recording is stopped, and then they still goes on with all of the stories that are also relevant for the study. So I guess that is one reflection. And in terms of the positionality with the health professionals, I think this is also interesting because we also work with the nurses and the midwives also, which are traditionally in Indonesia was seen somewhat also as a partner of the doctor, but usually the doctor are like the coordinator. And so what I'm trying to do in that moment is trying to be really open and trying to be really friendly with them. And therefore they are going out of that hierarchy zone and more into a very friendly and very partner-like environment. And so that was really helpful to help them open up a little bit about their struggles also as health professionals, and to help me navigate and find the patients' houses and recommend the other patients. So I think it all went quite well. Although I must say it's always a dilemma when what should I do during these moments, and I wish I can call Jeanette or Dick, but I cannot. So so I have to decide by myself, and those are the reflections.
Thank you.
Thank you.
Thank you very much. Professor Omitiaka, did you have an additional question?
Yes, certainly. And it's related to my question about how to involve the community and families more. And I was inspired by your answer on implicity and that it gives room to sincerity. I was thinking, yes, that is true, and that is maybe thinking that might be the reason why I always feel a little bit uncomfortable when they say we have to we have to involve the community because there will be a lack of resources coming, formal resources coming towards us. But then I also noticed that when you were talking about palliative care in Indonesia, you say there's a lack of resources, and therefore there is there are problems, and there also maybe therefore there is this community service. So how did you find, was that a struggle in Indonesia, or that the sincerity and the lack of resources maybe were, how do you say that?
Say it in Dutch.
Botsen, so that's not conflict. There's a conflict with him, sorry. Yeah.
Yes, thank you very much, highly esteemed opponent, for the question. So, yes, I think if we would like to reflect on it, it is can be perceived as a conflict. And I also reflect on how to involve community cadres, for example, how to involve them into palliative care. And when we reflect on it, we also think about this might something that impose more challenges, ethical challenges, because the volunteers are underpaid or even not paid because they are volunteers, so they only receive some transportation fee. But then we also want them to also provide more care. Usually the traditional way is the maternal care and child care, and now palliative care, more burden to them. Would it be okay for them to have all of this burden? And also, what are the boundaries of what can the volunteers do and which should be left to the families and the health professionals? And I think to answer the sincerity idea or notion would be to co-create this with the community. So to really involve them from the beginning of creating a new program or implementing a new edition. Do you actually want this, and how do you want to go about it? And then maybe from there, the flow will be better, and then the sincerity will still be preserved because it is still their voices, not us that is forcing. So it's like you are stimulating them to talk about what we actually want, so like Socratic methods a little bit to have that initiative and sincerity from the community members.
Yes, I think that helps. That helps also in how to deal with it here, I think. Do I have time for another question?
Go ahead.
Yeah. And that is really related to also my first question when I asked what can we learn, and you said something about the community, but also about the value of the religious values and how we could take note of them maybe better. And well, you studied it very well. It was a very interesting chapter to read, but there also were also local values. Do you think this study directly gives us implications of how we can what we can use in practice already, or do you think it's more an implication for research that we should do in the Netherlands, and what kind of research would that be then?
Yeah, so I believe that local values will be very different in different settings, but I also assume that the main concept, for example, the sincerity or to do more, to hope for a miracle, it is something that also quite universal in different, in the same religion but different place, and also in different religions because of the higher being that is controlling. So I guess it can still be relevant in terms of not the wording, but the main concept or the underlying idea of these values. So research that can be done is to also explore maybe what kind of values, what kind of terminology that they use. Are the concepts somewhat similar to those we found in Indonesia, or might be very much different? And I also imagine perhaps looking into the Islamic values in the Dutch way, whether they are interpreted similarly or differently. That would be my answer. Thank you.
Thank you very much, both of you. This concludes the periods of defense and opposition. I now request you to read the second part of the formula.
Having concluded the defense of my thesis and pending the decision of the doctorate committee, I would like to express my thanks to my highly esteemed supervisors and co-supervisor in particular, to those who have brought forward their criticisms, and to all who have attended this ceremony.
The committee will now retire for deliberation.
All right, please. Silence. Thank you.
Esteemed candidate, after due consideration of the thesis you have submitted, we have decided to grant you the doctorate. The supervisor, Professor Pols, is authorized to confer this dignity upon you in customary fashion.
I gladly accept the task assigned to me by the Rector Magnificus of the University.
All right, please.
Do you promise to uphold the principles of academic integrity, of honesty and diligence, transparency, independence and accountability in your work at all times?
Yes, I promise to do so.
By virtue of the power conferred to us on us by law and in accordance with the decision of the Doctorate Board of the University of Amsterdam, I hereby confer upon you, Raditya Bagas, Wicaksono, the degree of doctor and grant you all the rights pertaining thereto by law or custom. In evidence thereof, you will receive the degree certificate signed by the rector and the supervisor and confirmed with the Great Seal of the University.
Please.
Then regard the obtained dignity as an honor and privilege and never forget the attendant responsibilities which you now bear towards science and society. Having fulfilled the task assigned to me, I have the honor of being the first to address you as doctor and to congratulate you with the dignity conferred on you.
You may sit, please.
Dear Dr. Bagas, I'm so happy to congratulate you as a doctor and so proud. I should actually say doctor, because you are a practicing doctor already. What a wonderful trajectory this has been and what a beautiful thesis you wrote. I remembered that you visited us at the Philosophy of Care with your now co-promoter Amalia, who you persistently call Boo Melly. At that time, we did not know you would be joining us for a PhD so soon, and less did we know how you would do the PhD. You did the fieldwork importantly in the rural areas of Purwokerto area. On your motorcycle, off-the-road motorcycle, you visited families at home to discuss how they were dealing with the palliative phase in care, if they received support from professionals, family members, and what is of value to them in these last phases. Little is known about palliative care in these areas other than that professional interventions are scarce and medical care is, like in many places in the world, oriented towards a curative care. What you showed in your research is that if there is treatment, there may be a tendency to overtreat, also on insistence of the family. Also, the patient is often left out of decision making. You've been speaking about that in the defense. And this is a form of courtesy or protection to the patient. You wondered how to make space for palliative care in this setup. And to this end, you closely studied the local values in these situations. One of the important values is ikhtiar, which means trying everything you can to improve the situation. And this is where you suggested to intervene. Could palliative care also be seen as doing your best? And if so, would this then reduce the want for curative interventions, if these were available at all? Could this help the family to be ikhlas, accepting the approaching death of their relative? This is a very creative and smart way of thinking. I think it's very Cap Bagas, your trademark. I also think that this analysis is helpful in Western hospitals where similar problems emerge. But your heart, Bagas, clearly, passionately lies with Indonesian healthcare. And I'm sure your ikhtiar will be most importantly aimed at improving healthcare and palliative care in Indonesia. You wrote your thesis in an impressively short time. One of the ways you manage this, and this could be a lesson for many PhDs, is by disciplining your supervisory team in a meticulous way. You called us in persistently when you needed us, always preparing very clear questions on PowerPoint slides and taking precise notes on our comments and on the spot. You did not waste time. And unlike most other PhDs, you had time to do other things in your thesis appointment. And you became a father for the second time. Bagas, you were always a welcome presence in the department with your cheerful mood, happy presence, and generosity in sharing what you knew. We are very grateful for that. We will miss you, but as you taught us to be, we are a class about it. Fully supporting the good plans you have, and we hope that our paths will cross again. Also, a congratulations to your family. And I'll try to do it in Bahasa. Selamat untuk istrimu Tika, putramu Farsan, dan si kecil Falisa. Juga untuk orang tuamu. Kami bangga sekali Bagas. And now I learned a phrase in your local dialect from your paranymph, Krembok. We are very proud of you. And now Amalia will say it.
Dr. Muhaimin, the floor is yours.
Thank you very much, Janet. Good afternoon, everyone from Indonesia. I'm very sorry that I cannot be there lively in person. So I'm very thankful that we have this online system now. I have known Bagas medical student. He was front row in class, and he was also well known for being one of the straight A students in his batch. So to be honest, I never imagined Bagas. Maybe I think many of us in our faculty never imagined that he would be pursuing your career in bioethics, because Bagas was also well known as one of the student assistants in the Department of Anatomy. So I was a bit shocked when he called me, or I texted me, I can't remember, but I was in Amsterdam at that time. And you asked for my opinion, or maybe permission, if you could join our department. So I was excitingly shocked. I was not sure if bioethics would become too boring or too confusing for you, because, well, compared to anatomy, it was like a different world. So yes, here we are now. I am here now witnessing this very important and touching.
Thank you very much. It gives me great
touching moment.
Oh.
Yes. Sorry. So it has been my greatest pleasure and honor to work with Bagas. Your passion, enthusiasm, and discipline, like Jeanette said, was always there during our discussions. And I was not, sometimes I was worried that it would be too much for you, but that's not the case. I guess everything went well. How you worked was, it was amazing. We planned to finish A, and you came up with A and B and C, like Jeanette said. So congratulations, Bagas. We are all very happy and excited that you will be coming back here to Indonesia, not only because we will pass our test to you, but also because we all know that you will give new energy and strength to our department and our faculty with your kindness and compassion, and also with your moral values and resilience, which we hope would be infectious to others. So once again, congratulations to you, Bagas, and to your family, Tika, Farzan, and si kecil Valencia. Thank you very much.
Thank you very much. And congratulations also from here. It gives me great pleasure, most learned scholar, to congratulate you also on behalf of the Doctorate Board of the University of Amsterdam with the newly acquired honor. And hereby I declare this ceremony closed.